First of all, Ricardo and the committee, thanks for the invitation. It's always a pleasure being here. I love this part of the country. You won't believe it, I shaved my last time he called me mid of the summer Santa Claus. So I wanted to avoid that association. I'm coming closer as a senior to that group. But first of all, I want to thank Dr. Johnson Foy for the presentation. She mentioned a stepchild of aneurysm, and she had a cartoon of fusiform aneurysm. So Ricardo asked me, Dr. Hanel asked me to talk about fusiform aneurysms. They are rare. I don't even believe that they're aneurysms. I think it's the vasculopathy. It's a disease that currently we can control, I think, with our technologies, but we still don't have a proper understanding. So there are certain features to those aneurysms that needs to be discussed. Now, I'm not technical, but how do I advance with the green one? Yeah, there's some financial disclosure and interest here, but no conflict associated with the current context of the subject. So few facts over fusiform aneurysm of the basilar trunk. It's very rare, and it's interesting that unlike what you heard from Dr. Johnson, unlike in female kind of a higher incident of aneurysm, this is a male disease. So over 80% of the patients we see are male of different ages, starting from 50 all the way to 70, 80, and some of them are associated with aortic disease. Now, the mortality of this patient population, if we don't treat them, is over the next 5 years, 80%. And it's a bad disease. So it's basically a death sentence if you diagnose that. Most of the work was done in Japan, and they have a large group that they have been studying and publishing. And the mortality of endovascular treatment has been in this population very high, and I will walk you through the brief history and then where we are standing today. And surgery, I just spoke to a gentleman who's world-renowned in surgery of this kind of aneurysm. He's a Finnish guy, Harneshima, well known to my colleagues here. And they have done over 100 of those cases. And he tells now the patient when they are discovered with this aneurysm, please go home and enjoy your life. I have a different attitude. I think it's a little bit too fatalistic in the era of endovascular treatment. We have to give some of the patient chances. So early experience started when we were back in Buffalo, and you have heard Nick Hopkins also, who was running the program at that time. And we had our experience with stent-assisted coil embolization, which we then later published in Stroke. And we removed basically all other data set and focused on only in the basilar trunk. And it was interesting. This is one of the patient with a fusiform aneurysm of the basilar trunk. At that time, we had only coronary stents, which were very difficult to navigate to the brain. And we coiled around it, and the data looked very promising. I have to say, we had a lot of patients that we saved lives, and there were follow-ups 5, 6 years. Some of the patients had nearly 10 years follow-up, and they did very well. That encouraged us with the introduction of the flow diverter. We thought, well, if stents and coils worked in this area, why don't we embark the journey using flow diverters? You have heard about flow diverters a while. And then we put a prospective study in Europe, mostly enrolled patient. And the initial experience with the flow diverter was we placed the flow diverter, and like the cardiologist did, we placed the patient on dual antiplatelet. So we gave them Plavix or clopidogrel at that time and aspirin. And we said, okay, let us look at what happens. This is one of the aneurysms. You see the flow diverter, that's the white mesh-like graft across one of these patient, and the patient was at the time of the treatment already wheelchair bound. You see, we were basically treating only patients that had no other options. Either they had already stroke-like symptoms or they were wheelchair bound. So they were at the, and the results were very good. We got here on DWI some mini strokes, nothing to our surprise, because there's a lot of clot burden in these aneurysms. And this is how it looks at 6 months, and at 12 months, fairly gone, completely gone, some filling of the aneurysm, but the patient died a year later of pulmonary complications, most likely due to perforator occlusion. So brainstem injury that led to the death of this patient, unfortunately. And the other aspect was, how do we deal with these patients when they develop after treatment or at the time of treatment, a hydrocephalus? And I think there you will see from Dr. Malik also very good work, because they are on dual antiplatelet treatment, you have to stop. Some of our surgeons don't like to put a shunt for good reason because of the risk of the bleed. We have to stop basically these patients giving antiplatelet, and there is a risk that the whole construct thrombosis, like in the heart, we need to raise. So we analyzed then these subpopulation for basal, and the results were fairly promising, but the peri-procedure morbidity and mortality was very high. So we thought, let us start a prospective study and expanding and focusing only on this subpopulation. And as you know, in the anterior circulation, flow diverter has worked. This is a pediatric case here. You see here the 3D or the supraclinoid aneurysm treated. So the results were very promising over the last more than 10 years in treating this giant fusiform aneurysm in the anterior circulation. What is the challenge of the posterior circulation? The challenge is that we have a high distribution or high number of perforators that come out of the basilar trunk that make the treatment very difficult. This is a patient that did very well here from Dr. Lilik's group in Buenos Aires, treated for a fusiform aneurysm with a flow diverter. The contralateral vertebral artery was closed to avoid an endo leak, similarly what you do in the aorta. And this is 3 months follow-up, 14 months follow-up, and the entire artery has basically remodeled around this. Another young patient with a dissecting form, completely different disease entity than the previous cases, with a dissecting aneurysm, had a severe headache, impending rupture possibly in this person. So we treated him, we coiled him, placed the flow diverter, and you see the result is fabulous. 24 hours later, aneurysm is completely gone. However, the perforators, the tiny branches that supply the brainstem, went down. So you cured the aneurysm, but you gave the patient a massive stroke from which he won't recover at the age of 20. So this is a dilemma that we were facing. So when we then put together our data in this over 50 patients, what we found out was 27% of the patients, so these 52 patients, 27%, so nearly 1/3 of the patient had a morbidity and a mortality, and the all-cause of mortality in 17%. That's a big number in a patient population that obviously are not treatable, but to lose almost 1/5 of the patient from the procedure was unacceptable. However, when you do the subgroup analysis, what we found out was very interesting, that the reason for all these deaths were associated with infarctions. Less rupture risk after the treatment, but we were losing the branches that supply the brainstem, upper pons, mid pons, lower pons, craniocervical junction, etc. Now, what we did is, okay, let us split now the group of patients that present at an early stage of the disease. So patients where the aneurysms are still asymptomatic. So you see here the category of the patients that presented with a modified ranking scale 0 or 1, and there was only one patient we lost. So overall improvement of the condition was obvious when we treated the patient who didn't present with symptoms. Now that's not easy because these patients have such a bad disease that most of the referring physicians say, let us not treat it. The patient is asymptomatic, and wait until they become symptomatic. Now, what happens if we do the analysis of those patients that present already with the symptoms? Either they have stroke of the posterior circulation, or the aneurysm has grown to the size that it creates a mass effect of the brainstem. And here you see that many of the patients that presented modified rankings 3 or 4 died or had a major morbidity associated with the treatment. So you see the problem is that we waited very long. What about the occlusion rates and angiographic outcomes? The angiographic outcomes and occlusion rates were very high, almost comparable to anterior circulation, with nearly 70% of the patient complete aneurysm occlusion. So the summary of our early experience with flow diverter in the posterior circulation was that patients with symptomatic vertebrobasilar fusiform aneurysm had too unacceptable high morbidity and mortality rate. It's safer to treat these patients earlier and single implants. So instead of telescoping different implants, which increases the risk of perforator occlusion, was probably the way to go. And I remember Demetrius, who is sitting here, was promoting that a long time ago, and I concur with him after going through this journey. I think from our early experience, lifelong or long-term dual antiplatelet treatment was the way to go. Now, there were other people, other group members that have embarked the same journey, and they found the same thing, that if you treat these patients with the flow diverter and put them on dual antiplatelet, we have here a situation of high peri-procedure morbidity and mortality, which is unacceptable low. So what has changed? What have we changed? We have not changed the device. We have changed some ways, techniques that have improved, but we have done something different. We learned from subgroups that probably to put the patient on anticoagulation on top of antiplatelet may make sense. And we did some early, this is Bilbao, Frank Gehry, some of you know that. What we did is in a multi-center setting, we compared our data of patients, and Ricardo is one of the investigators in 8 different US centers, and this paper is just being published. I think it's online. What we did is we said, let us look at 2 patient population. One patient population that has dual antiplatelet treatment and the other population that had triple therapy, we call it. So we added to aspirin Plavix or Brilinta aspirin, we added Eliquis. So rivaroxaban or I think there were some other anticoagulants that were added. And let us compare the data. Obviously, there's a lot of shortcomings with data. It's a retrospective, it's a case series, it's centers that have a lot of experience. So we did the analysis. You see on the left side, the triple therapy in 14, it's a rare disease, like I said, in 14 patients, and dual antiplatelet, classical treatment like in anterior circulation of 13 patients. And there were some surprises that popped up. First of all, surprise, there were more patients that were sicker in the triple therapy. The reason is that people still are waiting because the old data was not present. So they were waiting to enroll them in the triple therapy. So where we had Eliquis on board or one of the anticoagulation. The other surprise was, and that has to do with all these newer instruments that we have developed, there were more radial access. And I have to say, radial access to the posterior circulation is so easy as compared to femoral access. It makes the procedure easy because of the configuration and relationship between the vertebral artery and subclavian. And it's very comforting for the patient. It's really a very straightforward procedure. Then what about numbers of devices used? You see there's a behavioral change. Initially in the dual antiplatelet treatment, 23 devices in many patients versus 3 devices. I said 1 device in a small number of the patients, 3, versus in 64% of the patient with triple therapy, single devices. So that means our learning and habit have changed over time. And that goes back, like again, I said, Demetrius said it a long time ago, we should have less and wait before we, telescope the devices. So that was one thing. The other observation was the outcome. And the outcome was very, very interesting. The decline in modified ranking scale was seen in the triple therapy only in 1 patient versus in 9 patients that had dual antiplatelet treatment. And that has to do with perforator strokes. Perforator strokes was the key leading cause for this patient population to get a damage to the pons and subsequently shift in the modified ranking scale. The complete occlusion, of course, dropped in the triple therapy because anticoagulation, we know that from patients who have AFib and get aneurysm treatment, that the healing response gets delayed. And that's to be expected. Now you're blocking all the mechanisms of thrombosis of an aneurysm. And we see that with coiling. And you see that's reflected in the study that you had only in 25% in this observation period, a complete occlusion of the aneurysm versus in the dual antiplatelet group. Some cases from our shop, here a patient with a basilar truncatum, you see this is an ugly disease, 6 months follow-up, some occlusion of the aneurysm. Another patient with a large clot burden, and he's 70, he has now lived for a few years. Here, one single flow diverter, we had to close the other vertebral artery. You can imagine there's an endo leak. When you look at that, there could be an endo leak from the back, and that's what we faced. So we closed the vertebral artery carefully, put the patients on anticoagulation to avoid perforator occlusion as well as occlusion of the pica, because suddenly you have dropped the blood pressure and the flow. This is how it looks after the treatment. And when you look in vaso-CT, you see nicely how the device covers the aneurysm. But you see also the problem. There's a distance between a major perforator and the device itself, creating the propensity for a stroke. So what you do is you want a remodeling of the device, of the aneurysm around the device without occlusion of these little perforators. And that's exactly what we do by keeping the patients on anticoagulation. Another patient with a Turnoff, younger patient in his early 60s, where we had a technicality issues because it's just too big arteries. We don't have the flow diverter. So what we decided is to expand the flow diverter with 2 stents. We call it the double barrel technology, and place a stent here. So the concept now is getting more and more just to focus the flow diverter on the segment that's diseased rather than placing the device in areas where we have a healthy normal perforators and a higher density. So we are reducing the implant, the length of the implant. So this is the cartoon that shows how we expand it further. And you see already at 3 months follow-up, the belly of the aneurysm is shrinking. So you are unloading the pressure on the aneurysm. And this is 1.5 years later on Eliquis and Brilinta, and you see most of the aneurysm has thrombosed, and the patient is doing fine. He's stable. And how is that possible? People ask me, how is that possible that you keep the perforators open? And the interesting thing, the perforator don't keep open. They close off, but they are what we call longitudinal new branches that sprout. It's the angiogenesis that sprout through the clotted segment. And you see that on the video clip on the left side, there are little branches that sprout between the device and the clotted area and reperfuse the brainstem. And that's the beauty about this progressive slow occlusion. Another patient, I will go quickly, 55-year-old with ataxia. Many people say, why are you treating that? The patient has the early symptoms. It's very easy to treat, and it's a very easy treatment. Maybe we can see the videotape here. Can you forward it? It's really the simplest way of deploying a flow diverter is the posterior circulation. It opens up always. You can titrate it exactly. Just go fast forward. So you place your device right there. You don't want to cover the perforators of midbrain up at the top. You place the device, you glow with your balloon or with your stent. Here we are anchoring the distal part with a stent. Here the device has been placed. We go, you can move a little bit faster. Yeah, keep going. Ooh, that's very fast. So you have your the device placed, then you go with the balloon, you open up the device with the balloon, and you anchor distally and proximally the stent. This is the ballooning. Very easy procedure for interventionalists who are used to do that. The problem is not the treatment with the device. The problem is what we are talking about is management of this patient with antiplatelet and anticoagulation. And that's the major shift, as you see. We can move forward now. Yeah, next slide. Yeah, this is how now the construct looks. Like I said, we want to reduce the flow diverter, which has higher mesh and more metal than stents. You see the stent anchoring here, and down the device extended into a healthy segment. And this is the final result. And the patient is alive a few years later, and the aneurysm is stable. Another subject, Same technology. Most of it is thrombosed. Ugly here, ugly kind of a web kind of a plaque here. Elderly patient. We treated him. The patient is now 5 years alive. The aneurysm is gone. There's a stability. Has the aneurysm disappeared? No. In some patients, we see the aneurysm still there. It doesn't go away completely. Another more complex case, completely different disease than the one of the senior person, which is atherosclerosis. This is a media necrosis, so we call it disease of the media muscularis with this fusiform aneurysm where we treated this guy. Again, we put it on triple therapy. So what is important is, and Ricardo, Dr. Henel has contributed a lot into this, that we differentiate. Whatever looks angiographically an aneurysm doesn't need to be an aneurysm. It could be an aneurysm, but it could be a completely different underlying disease, and the outcomes will be different. But these vasculopathies of the posterior circulation are a challenge. I think that we have to reclassify them. I think the fusiform aneurysms still remain a challenge for us, but I think we should really seriously consider treating these patients before they become symptomatic. So instead of doing every annually MRI or MRA follow-up on them and wait until the patient is wheelchair bound, I think we should intervene earlier. And the critical problem is the high perforator density. And I think less is better. Single flow divider probably better. And infrequently, we have to sacrifice the other vertebral artery. We consent the patient for that to avoid endo leaks. I think blood pressure management is important. Anticoagulation management is, and dual antiplatelet management is very important. These are patients that stay with you lifelong. Now, what will make a big difference, I think, is this newer technologies. I hope that Matthew Gunis will talk about that later. Who has been heavily involved in this. This is a new flow diverter that's heparin encoded. So the heparin stays there for a very long time. And I think this is an innovation that could be beneficial for the posterior circulation. Here's some research study from UMass, from Matthew's lab here, showing with OCT technology. And Dimitris, there I believe really this is critical for understanding in early stages what these implants do. Absolutely. Here, MRI showing nominal hits placed in the basilar trunk of the canine model, and very, very interesting results. And we think maybe there will be less endothelialization, but that couldn't be shown in this study. So you get the same endothelialization. It doesn't inhibit the healing response of the vessel and the aneurysm, but it inhibits basically clot formation in the perforator. So I think in the posterior circulation, this may make a huge difference. With that said, I thank you for your attention.